Okay, just so everyone is aware, a recording of this meeting will be done today for this public work group for the Children and Youth with Special Healthcare Needs training for EMS providers. This is our third work group, so please be aware of what you say, as this will be for public record. And Julia, I'm okay to share my screen if that's okay with you. Thank you. Okay, I see that Dr. Woolridge is present. Can you hear us, Dr. Woolridge? Okay, awesome. Well, I am gonna kick it off to you, Dr. Woolridge, if you just want to do welcome, and then I will go around roundtable for introductions today.
Can you hear me now?
Yes.
Okay, my screen was confusing me. I apologize. Okay, well, thanks everybody for attending. Looks like we have 10 participants at this point, so that's great. This is will be a working meeting. We're going to be doing this is now our third breakout meeting for developing our training tool in regards to children and youth with special healthcare needs. I think we're going to start where we left off last time with some of the assignments that were taken home. But I think first, Brianna, you want to do introductions first? Is that correct?
Yes, that would be great. Thank you, Dr. Woolridge. So I'm just going to go down the line, and if you can just say your name, where you're from, as well as what brings you here for the training today, that would be great. So first off, we'll start with, I see Noreen Adlin is on the call.
Hi, everybody. Noreen Adlin from the Bureau. I'm Deputy Bureau Chief.
Thank you, Noreen. I will turn over to Julia Vinton.
Hi, everyone. Julia Vinton, also at the Bureau, here for support.
Thank you, Julia. Adam Rodriguez.
Hi, guys. This is Adam. I am on the EMSC team with Aubriana in the Bureau of EMS.
Thank you, Adam. Jordana Carpenter.
Hi, this is Jordana Carpenter. I also work with the Bureau with EMSC for Children.
Awesome. And it's important to note that Jordana is our family advisory consultant on the EMS for Children team and is a big spearheader in this training today. I will start next with Doug Costal.
Hello, Doug Costal. I'm the EMS educator for Arizona Fire and Medical Authority.
Thank you, Doug. Glenn Trainer. Glenn, I will come back to you. Keena McBee.
Hi, I'm Keena McBee. I am the pre-hospital specialist over at Banner Del Webb.
Thank you, Keena. Dr. Rachel Munn.
Hello, my name's Rachel. I'm one of the emergency medicine and EMS physicians in Tucson, Arizona, and I'm a PACES member.
Thank you, Rachel. I appreciate it. Brian Smith.
Hi, Brian Smith. I'm the pre-hospital care coordinator at Flagstaff Medical Center.
Thank you, Brian. Glenn Trainer, are you able to come off mute today?
I am. Can you hear me, Aubriana?
Yes, I can hear you.
Hi, Glenn Trainer, Phoenix Fire Department.
Thank you, Glenn. Excellent, Dr. Woolridge. I believe that's everyone. Is there anyone that I missed? Hearing none, Dr. Woolridge, that concludes introductions.
All right, thank you so much. Aubriana, did you want to start with display? There we go, perfect. Okay, I think at this point we step through it, and strategy is to comment openly and kind of a free-for-all. I think our group is small enough that we can just use our mics. Brown, is that okay structure for you? Did you want to just step through each slide at a time, or did you want to start with individual interim assignments?
No, I think stepping through slide at a time, I was just going to touch upon the slide. Yeah, I think that's a good process of action, and we'll just move quickly through the ones we've already completed.
Great.
Okay. Excellent, Dr. Woolridge. So I'm just gonna, for those that are just attending for the first time, we did go over these learning objectives in our prior meeting. Is there anything that you saw prior to this meeting or that you see now that you would like to change or like to add? And I'll say if I see 3 thumbs up, I'm going to assume that we're good to move to the next slide. So I see 1 from Dr. Woolridge, 1 from Kina, 1 from Jordana, and 1 from Brian Smith. Okay, excellent. So these are newly revised slides. These ones have not been completed before. These are just some case scenarios we wanted to provide to EMS providers. One focuses on engaging with families and having them be involved in facility selection. Another focuses on feeding tubes, and then the other focuses on engaging the family during a ventilator emergency. So this one focuses on the facility selection. So I'll just have you read through the scenario and then the case resolution, and then I will ask that we discuss this and see what can be added or removed. And then for those on the call, I'll put this in the chat as well so you can access the slides yourself as well. Okay, so Dr. Woolridge, I see a thumbs up. Is everyone okay with the scenario, how it's written? Brian Smith, yes. And the case resolution is okay with everyone as well? Jordana, yes. Doug, I see your hands raised.
Oh, sorry, I did that on accident.
No worries.
It's my first day.
We all got to start somewhere, right? No, I'm just kidding. But thank you for just being active in the Google chat. So with that, I saw that we had 3 thumbs up to move forward. Can I just get a verbal yes from everyone that we're okay to proceed to case scenario 2?
Yes.
I'm good.
Yes.
Yes.
I like it.
Thank
Yeah.
you. Okay, so case scenario 2 is going to be on a feeding tube patient, specifically an 8-month-old patient that presents, and then case resolution as well. So I'm going to just remove for my own informatics, I'm going to just remove that quotation mark. But reviewing the scenario, do we have any questions, comments, concerns, revisions? Dr. Voyage, I see a thumbs up. Brian Smith, thumbs up. Rachel Munn. Looks like we have many that I couldn't record the other ones. Okay, excellent. Thank you all. I would just like to suggest for the group, did we want next to the case scenario too to put what specifically the case scenario is about. Do we want to put feeding tube next to it or G tube, or just leave it the way that it is right now?
Can you move back up? So case scenario 1, did we have a title for that one?
Just case scenario 1. So I didn't know if we wanted to title them specifically with what the case is relating to, or just.
I would say it would be okay to label them, but depending on how long the label would go. Some of them might be kind of wordy, so it might be better just to do case scenario 1, 2, 3, 4, 5.
Okay, thank you, Jordana. Is anyone else in favor of titling them, or do we want to leave them the way that they are?
I don't have personally strong feelings one way or the other.
I agree that some of them may be lengthy, so I think we should just move forward with case scenario 1, 2, and 3. But okay, Brian Smith says yes. Excellent. So we're going to move through, and then Keena, thank you. I'm going to move to the next case scenario then. This is specific to a ventilator-dependent pediatric patient. So if you can review the scenario, give me 3 thumbs ups if that one's okay, and then review case solution. And if I see another 3 thumbs up, I think we'll be good to move forward.
Brianna, one question I did have for the group regarding some of the ventilator scenarios and educational points in this module is when looking through kind of paramedic scope of practice in Arizona, the only item listed is to use automated transport ventilators. So I don't know how much ventilator education your non-critical care paramedic will have had in advance, or if it would even technically be within scope of practice to really troubleshoot or adjust a patient's home ventilator. I don't know if anyone else has more knowledge or thoughts about some of the ventilator-related cases or questions in this module.
Thank you, Dr. Gunn. That's excellent feedback, and I appreciate it. Does anyone else have anything regarding that?
I could probably give some feedback because we do ventilators with our inter-facility cases. We do provide some initial training when they come on board, and then continued education when it comes to ventilators. As far as the settings and the controls, those are set by what the doctor or the respiratory therapist gives us in the hospital, and that's what we continue to keep the patients set at. I'm not sure if that answers your question, doctor, but that's what we do.
Thank you, Doug. Keena, I see your hands raised, and then Dr. Woolridge, I saw your box move. So Keena, we'll go with you first.
Yeah, just to add on to Doug, when we do ventilator transports, it's generally taking whatever settings they're already at. If there are any questions, that's when we would actually reach out to medical control to help troubleshoot anything that we aren't comfortable with adjusting or doing for the patient.
Thank you, Keena. Dr. Woolridge, did you have anything to say before I answer Glenn Schrader?
No, I didn't, and if I made a reaction, I apologize.
No worries. Glenn?
So that's a good scenario. I think the resolution is just suctioning the airway, which is part of your like dope mnemonic. I agree with everybody else. I used to do all the training for AMR. I am a respiratory therapist on my days off from the fire department. We would not want to change any parameters on this case resolutions. I would just say return the vent back to the patient and stabilizers or whatever. I would prefer that paramedics or EMTs don't touch that ventilator.
Thank you, Glenn, for that feedback. And And I will start revising it after I answer Brian Smith.
Yeah, that was my thought. EMTs can't do anything with the ventilator, and many paramedics may or may not, depending, a lot of them don't have ventilators. It seems like it would be more reasonable since the father is so familiar with it, to note for the father to set the parameters rather than having EMS do it necessarily.
Okay, thank you, Brian. It's really great discussion, and I appreciate you all sharing. So from what I'm gathering is we may need to, the scenario is okay to leave as it is, but for case resolution, we need to, on this line number 4, EMS performs inline suctioning, and request that the father adjust the ventilating parameters. Does that, Brian, I see a thumbs up.
I think, Brianna, that might depend on what the goal teaching point in the case is. I think you could resolve it in a couple different ways. One being that suctioning was enough and the patient was able to go back on their standard settings for the father. Another could be a resolution that suctioning wasn't enough and actually valve mask ventilation was necessary, or that medical direction was consulted. I think the one key point that everyone has hit on is that probably most 911 response paramedics aren't going to adjust ventilator settings independently. So whether we remove that aspect, use a bag valve mask, contact medical direction, or have suctioning be the only treatment that's necessary, I think all of those could be potentially fine case resolutions. Sorry, that was a lengthy comment.
No, I appreciate it, Dr. Munn. I'm just trying to figure out how to write that so eloquently, as you said. So inline suctioning, bagged BVM, and consult medical direction. Does that cover all of the points?
All those could be options.
Okay.
I am driving, otherwise I would type something in the chat for you, but I'm also happy to look at it offline.
Okay, thank you.
I thought about this the other day when I was going through the material you sent me. Is the an EMT is not going to be able to do any kind of inline tracheal suctioning either. So how are you just, because this is my first meeting, I've missed the first two, but how are you delineating within some of these the differences in the scope of practice? Do you have a statement somewhere maybe that I missed that says that any skill in here that's noted has to be within the scope of practice of the provider?
We do not, Brian, and I thank you for bringing up that point. That is something that was an oversight on my end. So I think that would be good to include that in the initial, maybe before the learning objectives or after. What does everyone think about that?
I think that would be a great thing to include. You could also go one step further and say any skill or procedure needs to be within scope of practice and approved by the agency medical director, because there are some nuances between agencies.
Okay, thank you. And I will write that. I'm recording this meeting, so I will write that in the slides following. I think that's great verbiage. So I'm going to create a new slide above this one. And we'll just talk about scope of practice. Okay. Awesome. I will make that look better, but thank you guys for contributing that. So with us putting the scope of practice at the beginning of the presentation, if I leave this case resolution to include performing inline suctioning, bag valve mask, and or consulting medical direction, is that going to be okay for this group to move forward with that slide?
This is Glenn. Actually, I agree with what was it, Brian? That this is not, as a matter of fact, this is when I was working a lot of private ambo also, it was not a EMT skill. As a matter of fact, if an EMT showed up on scene and there's a tracheostomy, it got upgraded to ALS, and I would have to handle that call. They took the scope of practice of suctioning or managing tracheostomies from EMTs. It's an ALS call. So it's probably best to put a paramedic performs inline suctioning.
Thank you, Glenn. Okay. So is there any additional? Right.
So there's nothing about it's inline suctioning, bag valve mask, and or contact medical control. So we're doing away with the father setting the parameters back on the vent.
That was my understanding, but I'll leave it up to the group. Do we want to put the father adjusting the parameters on the vent? Or caregiver, just to make it more generalized?
I mean, if they switch, I don't have a problem if they switch to bag mask, and an EMT can do that too. I just wasn't sure that that's what we were going to do. So that's.
I think for the case resolutions, it clinically makes sense. We do have to kind of choose one resolution. While the things I listed off and that you wrote down are all equally plausible or possible resolutions, I think picking one will make the case make more sense. So if you want the teaching point to be that suctioning was the treatment, then you could say the paramedic performed suctioning with relief of the mucus, and the father was able to hook him back up to the vent or something like that, if that's how you want the case to go, if that makes sense. But I think having all three of those options is, it kind of confuses the case resolution.
And that would be EMT, not EMCT too.
Thank you, Brian. I think I'm going to, if it's okay with everyone, and Keena, I saw your hand raised. Yes, Keena.
No, I was just thinking, yeah, if you're doing the inline suctioning, maybe anything after that would be with the father setting the parameters on the vent, if that's what you wanted to add. Anything after that would be, if this does not correct the problem, then switch to a BVM or contact medical direction. That way it's specified that you're not doing all of those as a option out the gate. It's we're looking for inline, but if it fails, you do have two backups.
Okay. Thank you. And Glenn, I see your, thank you, Keena, for that feedback. I hope I'm writing it correctly. And Glenn, I see your hand raised.
The parents are not allowed to adjust these parameters. Those parameters are set. Those are set by the providers or the respiratory therapist or the home health care nurse. They stay. Because if you adjust any parameters, you can create more alarms. So reconnecting the ventilator, just like Dr. Munn said, is plenty fine. I think the case, if you just look at this case resolution and the learning item was just to suction this airway, that's good. If you guys want this patient to be transported and evaluated at the hospital, then go to the other one where you said you bagged that guy. What you can't do is you can't bag a patient that has a cuff that's on a ventilator. You can bag valve mask them all you want. Nothing's gonna go in there. Promise. You gotta bag it through the trach.
Okay, thank you, Glenn. I appreciate that feedback. So just to follow up on that, would the caregiver not be able to adjust the parameters for my own understanding? And then Jordana, I'll answer your question after. Glenn?
Yes, I think just reconnecting the ventilator to the patient would be adequate, and then it resolves everything.
Thank you, Glenn.
I feel that would be the best. But adjusting parameters, parents, we don't do that education when we send the patients home on a ventilator. We teach them about inline suctioning, but we don't teach them about parameters on a ventilator. They have to call somebody.
Okay, I see what you're saying, so that the paramedic or provider wouldn't be able to tell the father what parameters to adjust because they're not receiving that training.
Right.
Thank you, Glenn. Jordana, yes, I see your hand was raised. Sorry.
Not to like stir the pot or anything, but we do have some training as parents on our equipment at home because we don't always have the availability to call somebody to be able to get that direction from medical direction like EMS does. And we are fully aware that EMS usually doesn't have that kind of training. So parents do have some training to deal with those events, especially if they're in home care. But I agree with having it be bagging them and take them to the ER.
So on that point, should we put a note at the bottom? So maybe removing the father from the specific sentence, but say that the caregiver will typically know the adjusted settings based on lived experience. Is that something that would work, Jordana?
Yeah, because we have our own set of like guidelines that we have to follow as parents. So like when our kids go through something, we have our own kind of algorithm that we follow and procedures that we do at home to be able to troubleshoot before we call 911. 911 is kind of our last resort that we don't really want to call if we don't have to. If we can fix it at home, that's our first priority. So we do have some wiggle room to change things that we have already discussed with our providers who are taking care of our children.
Okay, and then Dawn, I see in the chat, welcome Dawn. Thank you for being here. We can word it that the parent caregiver can adjust based on established care plan. Okay. So is it okay, Dawn, I see that comment in the chat. Can I put that at the bottom of the slide, or did we want to try and keep it in the paragraph for the resolution?
I mean, I apologize because I did join late. Sorry, I had another meeting that ran over, so I know I'm coming into this. It sounded like, there might be some like discrepancies on who can do what. And I think it is important though that some, like to Jordana's point, there are times when we are given parameters that we're allowed to make certain adjustments based on established care plans that we have with our provider because of the ability of not being able to get access to a doctor or the specialist right away. So I don't want this scenario and the resolution to eliminate that. I think there has to be space in that and an understanding of that from the EMS side and comfort in that. So I'm not opposed to where we put it, but I want to be sure that, that's part of that conversation, right? Does this family have an established care plan that allows for some adjustments to be made and allowing that opportunity to happen?
Thank you, Dawn and Jordana, for that feedback. And I believe that is the main incentive for this scenario that was drafted by our family advisory consultants, is to really show that the paramedics can work in tandem with the caregiver to ideally ensure that that patient can be stabilized. So I agree that there should be some component on there to highlight that you guys do have that knowledge to help EMS in that scenario. So with that, if I have it highlighted, kind of emphasized, so it's not in the clinical medical direction, but it's italicized at the bottom. Does this work for everyone?
Can Can I add another thing in there too? With ventilation with the BVM, I think it'd be good to emphasize that they obviously would have to be on high flow oxygen too as well.
Thank you, Doug.
And it might be better to put the caregiver may have rather than will have.
Okay. Thank you, Brian. This was great discussion, everyone, and thank you for your feedback. I just request that we do a final read through, make sure that the wording's okay and that everyone's satisfied with what it says specifically for the caregiver, because I do think that needs to be highlighted. And if I get 3 thumbs up, then we can move to the next slide. Ryan Smith, I see a thumbs up. Tina McBee, thank you. Jordana Carpenter, excellent. Thank you. Doug Costle, thank you. Okay. 1 thumbs up, Dr. Woolridge, thank you. Okay, excellent. I saw another thumb, but I couldn't move fast enough to see. But so these slides, who are children with special health care needs, were some that we've done in the first and second work group. So I'll just ask that we take a brief look through, and if there's any suggestions, please let me know. If not, I'll look for the 3 thumbs up again. Brian Smith, Tina McBee, Dale Woolridge, Jordana Carpenter, thank you. Doug Costle, okay, great, thank you. Okay, excellent. And this slide just highlights the data and demographics. If I could just get everyone to give me a thumbs up if this is okay. This was developed in one of our first. Thank you, Dr. Lim. Brian, Kina, Dale, thank you. Okay, and Doug, awesome. Okay, so this goes back to parents and caretakers. So this slide was drafted in our first and finalized in our second round. So please just read through. And then our family advocates on the call, please let me know if this works well for you as well.
Brianna, one thing I thought just from this most recent discussion we had is on bullet number 2, I wonder if it would be important to help also like share that there may be, like, not only are they generally trained to troubleshoot equipment and respond to emergencies, but they may also have established care plans from the providers. So I think that's sometimes helpful because it kind of formalizes what the families might be trying to communicate, why they want to do or need to do what they are asking to do. So, and that might alleviate some of the concern about what the, having direction come from the families, that it's direction that may also be part of established care plans.
That's a great point, Dawn, and thank you for sharing that. I support that being in there. Does everyone else have any suggestions? Brian, I see that you support it as well. Glenn, Dr. Woolridge?
Yeah, I do support that comment. I did have one other suggestion though. it says since they are the experts on, I would say the experts on their child. And they truly are the expert on their child, not to imply the expert on the gamut of pathologies that may have some co-similarities. But they are definitely the expert on their own child. I don't know if anyone feels opposed to that.
I think that's a great point, Dr. Woolridge. Thank you. Rachel, I see you support that. Dawn as well. Okay. So I know I asked for 3 thumbs up. If I could just have that again, please. Kina, Brian, Dale, or Dr. Woolridge, Jordana, thank you. Excellent. All right. Moving forward, so baseline vitals. Again, this was started on our first work group and then finalized on our second. So if we just want to review for wording, see if there's anything additional we can add. And I see that that looks good on your end. You as well, Dr. Woolridge, Tina, Brian, Doug. Anything from our family consultants on the call? Okay, we are in support. Awesome. Thank you, Jordana and Don. Thank you. Okay, so patient communication, I believe this one was finalized in our second work group meeting. So please, again, just read through. I misspoke. This was as a result of our second meeting. So this slide is just being seen for the first time. So I would like some discussion on this if possible today. I think just for myself reading through this on this point right here, it may be obvious, but I think it's always helpful to just say draw on the caregiver's expertise and knowledge, just so that we're emphasizing to utilize that resource. Does anyone else have feedback or in support of that, or Dr. Moon, Dr. Woolridge? Doug, thank you. Ryan? Okay. And Jordana, excellent. Okay, so can I just ask for a verbal yes if we're okay to move to the next slide then?
Yeah.
Okay,
Yeah.
Dr. Woolridge.
Yeah.
Thank you all. Okay, medical history. This was completed the first work group and then finalized the second. So just a quick run through for wording. If everyone's okay with the slide, I just ask that we do a thumbs up, and if not, just do a thumbs down.
Can we maybe put something about the premise alert in here or no?
We can, yeah.
Instead of saying like they might be a part of the alert program, maybe we could also like just a little asterisk saying if they're not, think about doing a premise alert.
And I'm just trying to look. Thank you, Jordana. Okay, alert, the medical alert program, and then we'll just put an asterisk here for the premise alert.
Yeah, just as like a thought for the the EMS crew to be like, hey, if they don't have something that they can easily, you know, access, that it might be in their best interest to think about a premise alert for the next call that is out of that area.
That is a great point. Thank you, Jordana. Okay. Adding in that new verbiage for that first bullet point. Is that okay with everyone? Okay. And then just a verbal yes from everyone that we can move to the next slide with that addition. Or Brian, I see you're off mute.
Yeah, premise alert usually comes from the 911 dispatcher, is my understanding. And they're usually given when they're dispatched. So my question is, the intent of this is to, if they're not in a medical alert program, to have the care provider consider a premise alert with the local dispatch center. Isn't that what the kind of the gist of that would be?
It's a good question, Brian. I'm going to have one of our family advisory consultants, Dawn. I see that you have your hand raised.
Yeah, so while the premise alert is dispatched by the 911 dispatch center, we have one in our home. We had to do it through our local agency, our local fire agency. And then they submit everything to be put in through the dispatch center. So I think this is why we would recommend that if you're responding to a home that has a significant medical like this, and they are not enrolled or aware of such a premise alert, there's an opportunity to share that information, because to get a premise alert, it has to go through the local agency first.
Thank you, John, for that insight. Brian, does that help to answer the question, or is there anything additional you'd like clarified in the slide? Or
Well, it's the wording of this. The child may be enrolled in a medical alert program, if not consider a premise alert, but whom, where. So if a provider has a chance to, the idea is that the provider responds and has a chance to educate on how to get a premise alert into the system so they would know it in advance, then on, right? It's just, if not, provide a or consider a premise alert, but how? I think we need to.
that is a good point. Thank you, Brian.
I'll come up with some wording maybe in a second, but.
Thank you. I appreciate it. Kina, I see your hands raised.
Yeah, I think that since this is specifically for EMS education, I think that the majority of EMS personnel are already very familiar on premise alerts and how to actually activate them through the system. I don't think that's a whole lot of education that needs to be put in this, considering it's something that we do pretty regularly. But that's just my opinion.
I second that. This is Adam. I second that. Kina, that most EMCTs should be familiar with some variant of special instructions from dispatch, be it a premise alert or what have you. So I second that.
Thank you, Adam. And Dawn, I see your hands raised, and then we'll go to Jordana after that.
Yes, understanding that, I think our intention was families are not always aware of premise alerts. So this would be an opportunity for them to let the families know that that is available and an option, and to like offer that information to help the families work on getting a premise alert for their location. Because I've had several EMS visits and none of them prior to us doing a premise alert ever mentioned it to us about the benefits of us having that. So I think, and Jordana, correct me if I'm wrong, but I think that is the intent of this. It's not to educate the EMS responders on how to use the premise alert on their end. It's more being open to the idea that if there is no premise alert and they're responding to these homes, of mentioning it and educating the families that this is something that exists as a tool.
Yes, so I would second that. So we've had many 911 calls at our house and never once has EMS ever offered to have a premise alert. So it's more so to get that on the EMS's mind of, hey, maybe we should do this and inform the parents and see if, what information we can put on as a premise alert. Not necessarily training the EMTs on how to do a premise alert, but just that it's reminding them that it's there and to offer that to the families.
I do completely agree with that. I was just making sure that I think it's wonderful to put it in there as the reminder, right? This is the education for EMS. I was just in stating further, I don't think we need to expand on how EMS needs to put it in. I think just the reminder of it being there about the premise is enough without stating any in-depth way of how we're supposed to go about it.
Thank you, Jordana and Kina. So following off of that, Kina, I don't know if this does this work to not necessarily dive into the how for a provider to do it, but briefly mentions that they should educate a caregiver. Would this work, or should we reduce the verbiage?
Oh, no, it's absolutely. It's great because it's putting it in the education for them to consider it and talk about it and educate the family. But when it comes to anything further than that, it's like a bullet, like a reminder, do this. But when it comes to the actual processing of it, I don't think it's something that we need to put in there of educating EMS on how to set a premise alert. That was the only distinguishing thing I was trying to say, is that I think the notation of it is absolutely great, so they remember to tell the family, but we don't need to educate them on how to do it.
It's awesome. Thank you, Kina. And Dawn and Jordana and everyone that contributed to that discussion. Just circling back to the initial recommendation, Brian, does this verbiage work for you as well?
That's what I was after. It wasn't the EMS provider. It was that they are following up with a caregiver if they didn't get a premise alert and they don't have other stuff. So,
okay, thank you. This is very helpful for my understanding. So thank you all for contributing to this. Can I get a couple thumbs up so that we can move to the next slide, if that's okay? Okay, excellent. Thank you all. Okay, so just going off of the go bag, this was started on the first work group and then finalized on the second. So if we can just quickly review this one, and we'll close out on slide 16 if possible today.
Does the emergency information sheet, is that for like medications and medical history? Because I think that really helps advocate for patients with special needs that can't speak up and they have something attached with their medications and history.
It's a good question, Doug, and thank you for asking. I will defer to Jordana and Dawn for that.
Yes, an emergency information sheet is just like a down and dirty, kind of like a face sheet, right? So it's got their name, date of birth, it should have their allergies, their medications, their special needs of whatever is going on, so that way it's information that EMS needs and the hospital.
Thank you, Jordana. Okay, so I'm not hearing much feedback for this. So if Dr. Woolridge?
Yeah, I'm almost wondering, we have tracheostomy supplies, but along with that, should there be maybe ventilator supplies too? So tracheostomy / ventilator supplies?
Glenn?
Doc, we're just going to transfer them into our vans, but sometimes what's usually helpful for us is some of our inline suction devices don't fit certain kids. So it's very, very nice that the family brings their own French suction catheters that we can use that. That really helps us out quite a bit, but we're going to put them right on our ventilator.
Oh, okay.
And then, yeah. So we have tons of tracheostomies, but I like the tracheostomy there because there might be a specific tracheostomy that we don't carry. So if we needed to do a change out or anything like that, the tracheostomy would be good. Yeah, but we're going to put them on our own ventilator.
Got it. Got it. So we could put that.
Sorry, Dr. Woolridge.
Yeah, so we could remove that.
Okay, thank you. Dr. Munn, I saw that you came off mute.
Well, my only thought was sometimes it is helpful to have their home vent or home whatever just for transport home after their emergency department evaluation and things like that. So just a consideration. I honestly think it's fine to include ventilator supplies or leave them off, whatever everyone else thinks.
They do something. They will bring their ventilator and they'll bring it. Like a lot of times we had a patient when I was working for the fire department full time, and I would just transport them on their ventilator. The parents were very familiar with the ventilator. As long as we had a spare battery, or I can plug it into the ambulance, we'll take that ventilator with us, and we do. And sometimes we'll have a rep. We'll have a representative that can look at their ventilator, make sure it's operating fine, and gives it a once over. But yeah, that sounds good too. But that wouldn't fit in the go bag, would? Do you guys normally the tubing that's already on that ventilator usually stays with that ventilator. We don't change it out or anything. So yeah, if you want to bring that ventilator tubing, but I don't know how big this bag's gonna be. Sorry, just my input.
Well, I think I could go either way, like Dr. Munn had said. I mean, the bag is a euphemism, right? It's materials you want to travel with. So, but yeah, plus or minus, I don't feel strongly on that either way.
Okay. Thank you all for that discussion. I just want to have that question deferred back to our family advisory consultants as well. Glenn brought up a point of how big the go bag can be. Do you see that having ventilator supplies would be helpful on here as well as tracheostomy?
I'll venture forth and say I think the list looks good as is.
Okay. Thank you, Dr. Woolridge.
I think this is fine for training. I mean, parents are equipped to bring what they know they need, and you know, depending on the event and depending on the situation. I mean, we don't have a go bag, we have a go cart, a cart full of stuff. So size is kind of irrelevant from the parent's perspective. Just my own opinion.
I would agree with that. The parents are going to have exactly what they need to bring with them. We always have it kind of stashed away. So it may not be just a little backpack. It may be, like she said, like a wagon full of stuff that we need to take.
Thank you both. Okay, so if this looks good to everyone, I just kindly request that we do 3 thumbs up. Alrighty. Thank you all. So we are approaching the end of the hour, so I think it's good to conclude on slide 14. We do have about another half to go through on these slides, so I'm thinking that this may take another work group, and potentially we extend it out to an hour and a half, just so that we can finalize this training before our next PACES and Education Committee meeting. Dr. Woolridge, I see a thumbs up. Does that work for everyone else? Okay, excellent. Okay, thank you all. So, and Dr. Rollridge, I'll send it back to you, but just the next course of action, just so everyone's aware, is I will be sending out a doodle poll. I kindly request that you fill it out sooner rather than later, as this helps me to make sure that everyone can be included in these conversations. And I thank you for always doing that through these work groups we've been having. There are a couple more slides at the end that I would appreciate some people's feedback in. So we have one slide relating to neurodiverse children, specific to behavioral health emergencies, as well as sedating a patient. So if I could have some volunteers for that, that would be great. If not, we can always discuss it at the next work group meeting as well. In addition to that, we do have future considerations as well. So if anyone has any feedback, you can simply add it to this Google slide deck. I know some of you can't access that through Google. So if you have suggestions, please send them to me via email and I'll upload them up to the slide deck as well. And then if you have any resources you want to share, just please send those to me as well. Or if you can, upload them to the Google document. But with that, Dr. Woolridge, I will send it back over to you.
Well, other than to thank everybody for all their time. I know, everybody's time is valuable, so we really appreciate it.
Thank you, Dr. Woolridge. And I did just want to ask quickly with the group, we've been focusing heavily on the draft slides. I didn't know if we wanted to table agenda item 3 for future work group meetings, because that is a lengthy document. Just so that we can have the slides presented for PACES. Would that work for everyone? Can I see a thumbs up? Glenn, Dr. Woolridge, Jordana, Dawn, Doug, thank you. Brian Smith as well. Thank you. And I believe the rest is ADHS team. So I think that's okay with the rest of us. So again, I will be sending out a doodle poll. And just fill it out as quick as possible. Thank you guys. And Dr. Woolridge, I'll have you go to action item number 5, if you don't mind.
For formality, I now adjourn this meeting. Okay.
Thank you, Dr. Woolridge.
Everybody, 3 hours of your time. We'll see you on the next one.
Awesome. Thank you, guys. Bye.
Thank you.
Thanks, Keenan.